So good evening, everyone. Thank you so much for taking some time this afternoon or evening to join us to undergo a refresher regarding quality and risk coding with regard to our patients in the Steward Healthcare Network. We're incredibly appreciative of you taking time at the end of a long day, and we know how valuable your time is. So we want to make sure that the material we covered tonight is pertinent to you and is very helpful in terms of your practice. Let me start with a few housekeeping items. Number one, as I'm sure you are all aware, on the next slide, you'll see that this educational initiative is accredited by the Steward Healthcare Utah Association, and it's accredited for 1 hour of CME credit. We do ask that you just take as much credit as you are entitled to by virtue of your attendance. So if you spend 30 minutes with us, you are absolutely entitled to claim 30 minutes. If you spend the entire hour with us, feel free to again claim the entire hour. You should only claim credit to the extent that you've actually participated. We do want to make sure that you know that I have no conflicts of interest and there's no commercial interest in this presentation whatsoever. A couple of other housekeeping items. Number one, if you have any questions throughout the entire course of the session, you can feel free to click on the question and answer icon, which is at the top of your screen. Even if it's in the middle or the beginning of the presentation, you can certainly click on that, log on, and absolutely enter your question and we'll read it off at the end. In addition, if for some reason you're having trouble with the Q&A icon, you can log on to email at Steward Healthcare Network Quality at steward.org. And again, that email address will be included in the presentation on a few slides, so you can take a look at that. If you do claim CME credit, you will be getting a survey. And frankly, I ask all of you to fill out that survey to make sure that you get all of the material that you need. And so that I get an honest appraisal of exactly the work that we do and whether or not there are other things that we can do better. And finally, this is accredited by the Massachusetts Board of Registration in Medicine for Risk Management. It's designated for 1 hour of credits regarding risk management. And again, if you need to claim that when you're renewing your license, you can certainly do so. This slide basically has the agenda. We'll start out by talking about quality metrics, including 2 very important ones, depression screening and controlling high blood pressure. We'll then move on and spend the bulk of our time tonight talking about risk coding, just how important it is in documenting the severity of illness in our patients and the acuity of illness that our patients are suffering from. We'll talk about adult risk coding as well as pediatric risk coding. We'll talk a little bit about performance liaison support and how they can be of service to you. We'll also talk about health equity and the initiatives that we're undertaking to try and achieve an accreditation and what we're asking from you to help us support that. We'll talk, as always, about patient experience, which is the voice of the patient in quality. And then we'll talk a little bit about some of the Medicaid quality initiatives that are new for 2023. At the bottom of this slide, again, you'll see the question and answer feature. If for some reason you can't log on to the Q&A, it's SHCN.qualityteam@steward.org. Any question that you have that you can enter, feel free to email that address and we will be able to get that question and then we'll get the answer emailed directly back to you. On the next slide, you'll see some of the people that I'm joined by tonight. We have Ginny Rigo, who's our Vice President of Quality. We have Jess Blackburn, who's our Executive Director of National Performance Operations and heads risk coding. Joanne Zama, who's our Senior Director of Government Quality Programs, including Medicaid. Kim Moody, who oversees our Process Improvement Department. Dina Post, who's our Manager of Risk Coding. And Kelsey Reed, who's our Member Engagement Advisor and will also be helping with questions and answers. Again, I have incredible people with me, and if for some reason I can't answer your question, usually one of these wonderful people can certainly help. So let's go ahead and get started. Let's talk a little bit about some of the quality initiatives that we're working on for 2023. The first that I really want to highlight is depression screening. For those of you that may have remembered quality initiatives for Medicare Shared Savings Program, we noted that every patient aged 12 and older should have an assessment of whether or not they have depression at least once a year. The ideal way to do that is with a documented screening tool such as the PHQ-9 or the PHQ-2. The PHQ-2 has 2 questions, the PHQ-9 has 9. Every patient aged 12 and older should be screened at least once a year for depression. After the pandemic, we have seen really a legacy of behavioral health issues. We've seen social isolation. A lot of people have been out of work and are suffering financially. Many people have increased their substance abuse, and we're seeing just a lot of difficulties in terms of dealing with day-to-day encounters. So we're asking that every patient, especially after the pandemic, undergo a screening at least once a year for depression with the PHQ-2. We want to make sure that you understand that screening for the PHQ-2 can be done in advance of the visit, up to 14 days in advance, and you can email the patient the PHQ-2, you can send it to them, you can ask them to fill it out in the waiting room, or you can just do it yourself in the office. But it doesn't have to be done by a provider. It does, however, have to be reviewed by you on the day of the office visit and no later. If you review the PHQ-2 after that, you are not going to be getting credit for actually performing that PHQ-2 screen. The screening cannot be initiated after the encounter. The screening must be reviewed by a provider, and if necessary, follow-up recommended and documented. And if you have a structured field in your EMR, like with Athena or ECW, it's important to use that structured field when possible. On the next slide, you'll actually see the PHQ-2. It's 2 questions. And again, it's over the last 2 weeks, how often have you been bothered by little interest or pleasure in doing things, or feeling down, depressed, or hopeless? And you can score this as not at all, several days, more than half of the days, or nearly every day. A score of 0 for both questions really suggests that the patient is not afflicted with any form of depression. But a score of 1, 2, or 3, 4, 5, or 6 would certainly document a possibility of significant mood disorder, and it is something that really requires follow-up by you as the provider. That follow-up can be additional testing, medication, a referral to a provider who specializes in behavioral health issues, or any combination of the above. But you do need to review the questionnaire and document the score and what you have decided to do about it. Now, why is this so important? Well, number one, it's important because this is one of the screening that is required by our governmental payers. Medicaid and Medicare are clearly requiring PHQ-2s of at least every patient age 12 and older. And frankly, we think this is just good practice after the pandemic. The other reason why this is so important is that our current performance in depression screening is somewhere on the average of 20%. Now, some of you may be doing this and not getting credit because it's not entered into a structured field or it's being reviewed after the patient has left. But for those of you that are doing it, we want to make sure that you get credit by reviewing it on the day of the patient being seen, entering it into a structured field, and again, having a policy in your practice that every patient should be screened for depression at least once a year and or on every visit. That's up to you. But we really need to improve that 20% compliance more to 90, 95% to ensure that every patient is being evaluated for depression and is getting the treatment that they need. So again, this is one of our key quality metrics for 2023, the performance of a depression screen on every patient at least once a year and frankly, every visit. On the next slide, we'll start to move on and talk about controlling blood pressure, which is our second really important quality measure that we wanted to talk about tonight. So controlling blood pressure continues to be a challenge. Every patient should have a diastolic blood pressure of less than 90 or 89 or less, and a systolic blood pressure of less than 140 or 139 or less. We are seeing, at least with the American Heart Association and the American College of Cardiology, a strong suggestion that they will be moving towards a lower target blood pressure. But for 2023, the target is less than 140 systolic and less than 90 diastolic. Many groups are defining normal blood pressure as less than 120 over 80, and anything over 130 over 85 is considered hypertensive in many different communities. But for us today, it's less than 140 and less than 90. As we've talked about before, it's every patient age 18 through 85 should have a documented blood pressure on every visit, and it should be entered into a structured field. It is the last blood pressure of the year that counts. And so if you see a patient in October and in April, the April blood pressure may be controlled, but if the October blood pressure is elevated, you will not get credit for having control of blood pressure in this patient. It is extremely important that that last blood pressure of the year be well controlled at less than 139 over 89 or less. There are several exclusions. patients in hospice, patients with end-stage renal disease, patients who are frail, or patients who are not admitted to an acute care facility like a nursing home. But again, for us today, we are recommending that every patient have a blood pressure checked on every visit, that that data be entered into a structured field, and that hopefully it is less than 139/89 when you're entering that data in. If your medical assistant notes a high blood pressure and you check it after when you come into the room, please make sure you document that repeat blood pressure in a structured field. If you enter it into the physical exam section, you will not get credit for that blood pressure. Now, what happens if that blood pressure is elevated? On the next slide, we're seeing more and more discussion of a phenomenon known as white coat hypertension, which is a blood pressure of greater than 130/80, but less than 160/100 after 3 months trial of lifestyle modification. Many patients will tell us that their blood pressures are normal at home, but are elevated in the office because they're anxious or nervous when they come to the doctor. White coat hypertension affects probably 15 to 30% of patients who have high blood pressure. And clearly, anxiety and stress will make a blood pressure become elevated. But if you see a blood pressure that's greater than 130/80, but less than 160/100 in the office on 3 separate occasions, it does now require either ambulatory blood pressure monitoring for a 24-hour period at an outpatient, or a home blood pressure monitoring reading with documentation of that in the medical record. You can do that as a nurse's visit. You can enter that as a subsequent reading when you're seeing the patient in the office. Or you can just enter it in as a regular office visit with the documentation that the readings were obtained at home. If the blood pressure is indeed less than 130/80, you can then treat that patient as having white coat hypertension and treat that patient with lifestyle modification and an annual ambulatory blood pressure monitor or home blood pressure monitoring to detect whether or not the blood pressure is progressing. But if the blood pressure continues to be high at home, then you really are obligated to begin antihypertensive therapy in conjunction with lifestyle modification to get that blood pressure under control. So again, if you are seeing white coat hypertension in your patients, it requires now a documentation of whether or not the blood pressure is normal outside of the office with either ambulatory blood pressure monitoring or home blood pressure monitoring. And again, if that blood pressure is controlled at home, lifestyle modification is purely the course of therapy with an annual follow-up. But if the blood pressure is elevated, one does need to consider medication and additional lifestyle modification. So these are the 2 quality measures that we're continuing to focus on for 2023. We've talked a lot about diabetes in the past. In January, we spent a lot of the talk discussing the 5 things that are required for diabetics. But I wanted to highlight for you depression screening, again, given the opportunity to improve our performance there. And I wanted to highlight again how important controlling blood pressure is and making sure that it's the last blood pressure of the year. It's got to be well controlled at less than 139/89. And that when you see an elevated blood pressure, it requires a follow-up blood pressure reading outside of the office, preferably with a home blood pressure monitor. So these are our 2 important quality measures that I wanted to attend to. On the next slide, you'll see that we're going to now move and talk about risk adjustment and risk coding. And I'm going to spend the bulk of the rest of the discussion talking about this. First of all, what is risk coding? Risk coding is the documentation of the severity or acuity of a patient's illness using ICD-10 codes. The average of all of the risk codes together will depict whether or not the patient has a significant medical condition, and we add those numbers together and we come up with what's called a risk adjustment factor. The combination of all of these ICD-10 codes have weighted factors associated with it, and those weighted factors together come up with a risk adjustment factor or a RAF score. For your knowledge, a RAF score of 1.0 tells you that your patients have an average amount of medical severity of illness compared to the average patients in your population. They're normal. They have the same acuity of illness as an average person. A risk adjustment factor of greater than 1 depicts patients that are sicker than normal or sicker than average. And a risk adjustment factor of less than 1 depicts patients who are healthier than average and again, would suggest that those patients are not nearly as sick as the average patients within your medical community. When you are coding and choosing ICD-10 codes for your patients, if you take one message home tonight, I would hope that you take home the message that using unspecified conditions for risk adjustment really is not the way to go. While many unspecified conditions will risk adjust, the majority of unspecified conditions do not risk adjust and do not have any value towards that RAF score that we were talking about. Providers may select an unspecified code instead of identifying the diagnosis that accurately depicts the severity of illness, but this will often lead to inaccurate coding and frequently a less or lower risk score than the patient really deserves. Specified coding really allows each provider reviewing the patient's chart the information and the specificity they need to adequately allocate proper care and resources in terms of providing better outcomes. Why is that important? Well, the risk adjustment factor or the risk score tells the payer, Blue Cross or Blue Shield or Harvard or Tufts or Medicaid, how much money they should be paying per member per month in order to adequately care for that patient and provide the resources that are necessary. The lower the risk score, the lower the per member per month. The higher the risk score, the more dollars come to Steward Healthcare Network and to providers. Those dollars are there to adequately allocate for the care and resources you need, and they're also there to be part of your distribution payments. Now, when we come to unspecified codes, if for some reason it's the most accurate code to select, like if you're seeing a patient for the first time and they tell you they have a history of diabetes, but they can't tell you anymore, then go ahead and use that unspecified code for the first time. However, as soon as you get additional information, please consider coding to the highest level of specificity based on your knowledge of that patient's active condition. And on the following slides, I'm going to give you some examples of unspecified codes and specified codes and show you the difference in what that means for risk score. So here I have two different depictions of depression. The first is major depressive disorder, single episode, unspecified. This does not accurately depict the severity of illness because you're not knowing whether or not this is mild, moderate, or severe depression. It does not provide for good continuity of care, and it does not risk adjust as unspecified. So you may not be receiving the appropriate budget to manage your care that you need to provide. What does that mean? The risk score from this ICD-10 code is 0. You get no credit for documenting this as the diagnosis for the patient. Option 2, however, is major depressive disorder, single episode, severe without psychotic features. Now here the difference is the severe without psychotic features. This ICD-10 code allows each provider reviewing the chart the specificity they need to allocate the proper care and resources in providing better outcomes. The psychiatrist will look at this and say, I need medication or psychotherapy or other options in terms of providing care. The PHQ-9, which is again a survey similar to what we showed you earlier with the PHQ survey, will determine the severity of illness. And this risk adjusts at a higher value and accurately depicts the severity of illness. This, therefore, allocates dollars to the budget to manage the patient's care. And the risk score here, just by adding severe without psychotic features, increases the risk score from 0 to 0.309. On the next slide, you'll see an additional example. Here we're talking about peripheral vascular disease with diabetes. In option 1, we are using two codes that both end in 0.9, which mean that they're unspecified. Type 2 diabetes mellitus, E11.9, and peripheral vascular disease, I73.9. The risk score here is 0.105 for the diabetes and 0.288 for the peripheral vascular disease. And here we get a combination risk score of 0.393. However, in this case, one code, diabetes with peripheral vascular disease, E11.51, is the right code to use and calculates to a risk score of 0.59, or almost 50% higher than the risk score using two codes. And so with the transition to ICD-10, there are many specific risk codes that document two diagnoses together that adequately and accurately capture a patient's healthcare picture completely and really gives the appropriate amount of denoting of severity of illness. Sometimes one does need to use 2 risk codes instead of 1. An example here would be type 2 diabetes with chronic kidney disease. Whenever you're documenting chronic kidney disease, you do document the stage. And again, there are 5 stages, stages 1, 2, 3, 4, and 5. And N18 basically will have 0.1, 0.2, 0.3, 0.4, or 0.5 for those patients depending upon the severity of their chronic kidney disease. So in this case, you do document type 2 diabetes with chronic kidney disease, E11.22, and you document the stage of the chronic kidney disease at N18.4. Instead of having chronic kidney disease, you now basically have diabetes with chronic kidney disease and chronic kidney disease, giving you a risk score of 0.591 with the 0.302 from the diabetes and the 0.289 from the chronic kidney disease. Again, a significant increase by using both together compared to either one as an individual. Another example of when you need to use combination risk codes is when you're documenting alcoholic cirrhosis of the liver. Whenever you document alcoholic cirrhosis, one needs to also document whether or not the alcohol dependence that caused the disease is either in remission or whether or not it's ongoing. In this case, I've documented alcoholic cirrhosis of the liver, K70.30, and alcoholic dependence in remission, F10.21. This gives me a combined risk score of almost 0.7, 0.329 from alcoholic cirrhosis of the liver, and 0.363 with alcohol dependence in remission. Together, 0.692, again, accurately depicting the severity and acuity of this patient's illness by using 2 codes in these 2 examples. On the next slide are some pearls that I'd like you to take away from. Number 1, the level of specificity in ICD-10 does help reduce errors and confusions when billing, leading to fewer rejected claims. It also, when you code correctly, will reduce the frequency of claims that are denied for lack of medical necessity. Secondly, providing accurate and specific diagnoses and coding will reduce the need for documentation requests by payers to support the diagnoses that are being reported. Again, accurate and specific diagnoses decrease the likelihood that the payer is going to come back and say, I need more information before I'm going to pay your claim. Third, providing specific documentation and support will reduce or eliminate the need for follow-up queries or educational opportunities, and this will result in your bill getting paid faster. You are much likely to get reimbursed from the payers when you use very specific codes as opposed to using unspecified codes. Fourth, transparency is extremely important when it comes to clinical documentation. A specific diagnosis and ICD-10 code that supports the diagnosis keeps an accurate clinical picture not only for yourself, but for people covering you within your practice, primary care doctors, specialists, and hospitals that are working with you. And finally, providers have an obligation to document conditions to the full extent of their clinical knowledge at the time they see the patient. This means that in some cases, you can't know the specificity of a condition. Again, if you're seeing a patient for the very first time and they give you a history of hypertension or diabetes or hyperlipidemia, you may not know much about the details of the diagnosis. And again, unspecified may be the only code that should be used at that time. But as you treat a patient over time and get more information, you should move away from that unspecified code and use a more specific diagnosis to give you the type of documentation that will accurately depict the severity of illness. On the next slide, I want to show you again a comparison of 2 examples of the same patient with different types of coding, one unspecified on the left and one specific on the right. This is a 39-year-old female with diabetes, chronic kidney disease, atrial fibrillation, asthma, depression, and cirrhosis. She takes a bunch of medications and she uses alcohol significantly. On the left, you'll see a lot of diagnoses that are coded in 0.9, E11.9 for the diabetes, N18.9 for chronic kidney disease, J45.909 for asthma, K74.6 for cirrhosis, F32.8 for depression, and I48.91 for atrial fibrillation. This gives a risk score of 0.853. Now, remember, we talked about the fact that a risk score of average acuity of illness is 1.0. Less than 1 would suggest that a patient is healthier than average. When you look at these medical conditions and this age, it would be hard to suggest that this patient's acuity of illness is less than average and that this patient is healthier than most. But that's what that risk score is conveying. On the right, you'll see coding with specific conditions. So here we've got type 2 diabetes with chronic kidney disease. We've got end-stage renal disease, N18.6. We've got dialysis dependency, Z99.2. Moderate persistent asthma, J45.4. Alcoholic cirrhosis with K70.0. And again, we coded the alcohol dependence at F10.20. Severe recurrent major depression, again, like we talked about a couple slides ago at F33.2. And permanent atrial fibrillation at I48.21. So we've really got the same diagnoses that we had, the exact same patient, same age, same medication, same alcohol use, but here the risk score is 2.63. This conveys that this patient is dramatically sicker than most. And with this risk adjustment factor, this will lead to additional severity of illness being conveyed to the payers and will result in increased reimbursement from the payers to ensure that you're getting what you need to care for this patient on a per member per month basis. Again, that risk score of 2.63 suggests that this patient is far sicker than most. And again, with specific conditions, we're able to clearly show how important this is in terms of obtaining an accurate risk adjustment factor, an accurate risk score, and an accurate depiction of the severity of illness for this patient. On the next slide, we'll talk a little bit about pediatric risk adjustment. We've been talking about mainly adults, but I do want to spend a few minutes talking about pediatric risk adjustment. When we're talking about pediatric risk adjustment, we should be again coding for conditions or health problems that last over 3 months, affecting normal activities and may require hospital visits or extensive medical care. Children with chronic illnesses may be ill or well at any given time, but always live with that condition. And examples of these chronic illnesses that may find a child well at times, but still having the potential for problems includes asthma, diabetes, sickle cell anemia, epilepsy, congenital heart disease, or cancer. In addition, depression is often a chronic condition that is overlooked and misdiagnosed, maybe masquerading as substance abuse or even a medical condition in children. Children with depression often present with headaches, stomach aches, and mood swings. And we'll talk on a few slides about some of the conditions that may code as behavioral health abnormalities. Finally, childhood obesity is becoming an epidemic. With the social isolation and inactivity associated with the pandemic, approximately 20% of our children are now obese. And this can increase the likelihood of developing other conditions, including high blood pressure, diabetes, back pain, anxiety and depression, sleep problems, and even blood clots. On the next slide, we'll talk a little bit about some of these chronic conditions. First, childhood cancer. Most childhood cancers are now curable, and leukemias are now accounting for almost 30% of all childhood cancers. Acute lymphocytic leukemia, chronic myelogenous leukemia, acute myelogenous leukemia, and juvenile myelomonocytic leukemia all have survival rates between 50 and 90%. And even if the patient is cured and the cancer appears to be in remission, you should still be coding for this to ensure that the patient's medical severity documents the fact that they are a childhood cancer survivor. Secondly, epilepsy is the most common childhood brain and neurologic condition in the United States. Fully 2/3 of children with epilepsy will outgrow their seizures by their teenage years, but you should diagnose epilepsy or a seizure disorder and code for it if a child has 1 or more seizures, if the provider thinks the child is likely to have a seizure again, and the seizure was not directly caused by another medical condition such as hypoglycemia associated with diabetes or a febrile seizure or infection. In addition to childhood cancers and epilepsy, congenital heart disorders do not always need treatment, but they sometimes do require several surgeries or interventional procedures. And while many congenital conditions are relatively asymptomatic, they should be coded for life so that, again, This can depict the severity of illness and the follow-up that's required, including cardiology, echocardiograms, EKGs, and other follow-up testing. These include atrial septal defects, patent ductus arteriosus, ventricular septal defects, and tetralogy of Fallot. On the next slide, we'll start to talk a little bit about some of the emotional disturbances that we see in children. Children with severe emotional disturbances are children under the age of 18 who have a diagnosable mental, behavioral, or emotional disorder of sufficient duration that it meets criteria specified within DSM-5. It usually will result in functional impairment and interfere with or limit the child's role or functioning in family, school, or community activities. For a developmental disorder to be pervasive, it must be characterized by delays in development of multiple basic functions. And again, while not all pervasive developmental disorders are yet identified, the best known of these include autism, severe Asperger's, Rett syndrome, and childhood disintegrative disorder. And I've included these ICD-10 codes for your reference. Atypical autism is at F84.1, Asperger's F84.5, Rett syndrome F84.2, and childhood disintegrative disorder at F84.3. Childhood schizophrenia is coded the same as an adult schizophrenia at F20.9, but it usually occurs early in a child's life as opposed to the early 20s, which is common in adult schizophrenia. It typically affects and has serious implications for a child's development, and it will require lifelong therapy, and again, should be coded throughout the life of the individual. On the next slide, we'll start to talk a little bit more about affective and mood disorders. Affective disorders are psychiatric illnesses that affect mood, such as depression, pediatric bipolar disorder, and childhood anxiety disorders. If they are acute enough to seriously impede a child's development, they may well qualify as a serious emotional disorder. And here again, I've listed the most common: bipolar disorder at F31.9, post-traumatic stress disorder at F43.1, panic disorder at F41.0, mixed anxiety disorders at F41.3, major depressive disorder, severe without psychotic features, and severe with psychotic features at F33.2 and F33.3, and an unspecified persistent mood disorder at F34.9. On the next slide, you'll see depiction of disruptive behavioral disorders, often known as oppositional defiant disorders. These are serious patterns of negative, defiant, disobedient, and hostile behavior that persists over a long period of time. This is not a child who has a temper tantrum. It is serious, long-term behavioral abnormalities, including propensities towards aggression, harming of animals, destruction of property, stealing, or even self-violence. And again, these include oppositional defiant disorder, ODD at F91.3, or emotional disorder of childhood at F93.9. And then on the bottom of this slide, I included self-destructive behaviors, including psychoactive substance abuse, F19.1, suicide attempt previously at T14.91, anorexia at F50.0, and bulimia nervosa at F50.2. Any disorder that could lead to serious chronic medical implications, such as persistent substance abuse, attempted suicide, or eating disorders, will usually qualify as a serious emotional disorder, and again, should be coded over the long term to document the severity and acuity of illness and the likelihood of needing therapy. Next slide. So let's move on. After talking about risk coding, I wanted to just again reinforce how important risk coding is in determining the severity and acuity of illness. If you take one thing away from tonight, if you see a code that ends in 0.9 and can use a more specific code, please do so. And again, when you're coding that patient as you're leaving the office, make sure you take an extra 10 or 20 seconds to select the code that accurately depicts the severity of illness. When you see a patient that has one or two problems and they're chronically ill, take a minute again to document as many of those chronic medical conditions to accurately depict the severity of illness and to make sure that our organization and you have the funds you need to care for that patient over a long period of time. Now, we've talked about quality measures, we've talked about risk coding. I want to move on and talk a little bit about the people that are likely to help you with this, and those are our performance liaisons. Prior to the pandemic, many of you had performance liaisons interacting in your practice physically on site for days at a time. Performance liaisons have, unfortunately, like other things with COVID, begun to work more and more remotely, but we are starting to see some of them go back. What do? Well, they support practices to improve performance, and they do that by pre-visit planning, looking at quality gaps and risk coding gaps, and noting them either on a tab or in a yellow sticky note to make sure that you're aware of those opportunities when you see the patient. They also will do post-visit review to make sure that you've identified those gaps and closed them. They track all their findings in a performance tracker, which is available to you. And they should be developing and distributing rosters on a monthly basis to make sure you get as much information as you need to know which patients need your attention, which diabetics need a hemoglobin A1C, which hypertensives need their blood pressure checked, and to make sure that you know who needs cancer screening and in what form. We in Massachusetts are working to target certain payers, and frankly, all over the country, we've identified certain payers as the ones that we're looking at with the most intensity. In Massachusetts, we're looking at Mass Health, Blue Cross Blue Shield of Massachusetts, Harvard Pilgrim, Unicare, and Tufts. In Ohio, we're looking at Anthem Commercial and Highmark Commercial. In Florida, we're looking at Florida Blue and FHCP. In Utah, we're looking at Regents, Humana, and PEHP. And in Arizona, we're not doing risk coding, but we are looking at quality for HCA and United Healthcare. Our performance liaisons are there to support you, and we would ask that if you have a question or concern, reach out to them. They can be another set of eyes and ears to help identify those patients that need a little extra attention, a little extra help in making sure that we've got their quality gaps closed and the risk coding accurately depicting the severity of illness for them. On the next slide, I want to start to talk a little bit about health equity, which is an additional area where we're asking for your focus this year. As I'm sure you are all aware, there has been increasing attention to health equity. The pandemic has made it clear that not everyone is likely to have the same outcomes in healthcare, and that those that are socially and socioeconomically disenfranchised by the healthcare system have more difficulties achieving the same outcomes. And so we are working very hard to try and normalize those significant barriers that many patients face when dealing with the healthcare system. On the next slide, you'll see the things that we're asking for you for this year. And that is, we are collecting data of patients' race, ethnicity, and spoken language from every patient that you see. We are asking for you to collect in your practice the data on race, ethnicity, and language for every patient. So what are we asking? Number one, please activate your electronic health records, race, ethnicity, and primary language fields. If you used paper, make sure your forms are updated so that on the paper forms you can update with race, ethnicity, and language. And to the extent possible, please make sure the drop-down menus for race and ethnicity use the Office of Budget and Management standard categories or the Center for Disease Control standard categories to define race. What does that mean? So for race, we're asking people whether or not they'd like to be identified as Black or African American, Native Hawaiian or other Pacific Islander, white, Asian, American Indian or Alaska Native, some other race, and we are asking to try and avoid using declined. For ethnicity, again, we're asking whether or not the patient would like to be defined as Hispanic or Latino or not Hispanic or Latino. And again, we're trying very hard not to use decline. And for primary spoken language, we're asking for their language, whether that be English, Russian, Portuguese, French Creole, whatever the language is, we want to document it in the health equity data collection system so that we can look at that data and obtain that. We would like you to develop a policy and procedure for how this information will be collected from patients. Again, it can be done at your front desk, it could be done by your medical assistant, it can be done by you, but a standardized process should be in place for you to get this information at your practice. And we want to please ask if you can use questions to reduce the number of decline responses. So if a patient says, you know, I don't really want my race defined, there are ways to appropriately ask if you can collect that data anonymously and have it in the health record so that it again it depicts the severity of illness for these patients and other barriers for certain patients that allows us to do something to help them. Again, we are looking to try and decrease the barriers to obtaining adequate health care. And getting this information, especially after COVID, will help us to identify what we need to do to make sure that every patient has an opportunity to get great health care in every setting where they interact with medical providers. So again, we're asking for your help in collecting race, ethnicity, and primary spoken language information for every patient that comes to your practice. Next slide. I want to now talk about patient experience. You and I can debate whether or not patient experience has the same quality value as a hemoglobin A1C or a blood pressure or a mammogram, but every payer now uses patient experience as a quality metric. And every patient that you see will likely be getting a patient experience survey from Press Ganey within minutes of leaving your office. We've looked carefully at our data, and we really believe that these 5 specific questions drive patient loyalty across Steward and the healthcare network. Number 1, how well your staff work together. Did the receptionist and the medical assistant and the doctor all talk to one another and convey your concerns? Number 2, did you as a provider explain the patient's problem in a language they could understand and words that they could understand? And did you show concern for questions or comments that the patient had? Number 4, what was the courtesy of the registration staff? Were they pleasant and easy to deal with? And number 5, how long did a patient have to wait? We know that these specific factors are the focus for 2023 and clearly are what's driving patient experience across most of Massachusetts and the United States. And we're asking for you, when you're seeing a patient, to be cognizant of these. These are the things that you really need to be spending time with your staff and with your patients. And as providers, making sure you explain a patient's diagnosis in a language they understand, and you ask them if they have questions and answer them in a language that they can understand. This is crucial to great patient experience. And again, this is part of the quality metrics in every plan, commercial, governmental, Medicaid, Medicare. Every plan is using patient experience as the voice of the patient and a quality metric in terms of determining whether or not you've met quality gaps for 2023. On the next slide, you'll see how we're going to go about educating for the second quarter of the year. We'll be talking about, again, care provider concern for questions and whether or not the provider explained the patient's problem in a language they could understand. In April, we'll talk about being present for the patient. In May, we'll talk about demonstrating empathy and compassion. And in June, we'll talk about the teach-back technique and shared decision-making, making sure that the patient understands and can paraphrase back exactly what you explained to them. Next slide. I want to move on and talk a little bit about some of the Medicaid specific quality metrics. Again, we're seeing this in Ohio, Pennsylvania, and Massachusetts, but we believe that these are coming across the country. And there is a very specific emphasis on prenatal and postnatal care. Now, you may say that this is really something for obstetrics and gynecology, but I will tell you that every patient should have good prenatal care and postnatal care, and it can be done by primary care provider, an OBGYN, or any individual who has experience. Why is this important? Well, first, this is a measure that looks at the patients who gave birth between October 8th of 2022 through October 7th of 2023. That means the year is already half over for this quality metric. And again, we're asking for every patient who is pregnant during this period of time to have an evaluation that includes the following. And if you go to the next slide, you'll see that the patient needs to be pregnant and the date of the prenatal visit needs to be measured on the EMR slip. And then it includes one of the following. Number 1, listening for fetal heart tones or a pelvic exam or measuring the fundus height. Number 2, ordering blood work or an ultrasound that basically has to do with appropriate prenatal care. Number 3, prenatal risk assessment and counseling or a complete obstetrical history. Any one of those will give you a credit for completing this prenatal care visit. And again, while prenatal care is usually the province of an OBGYN, because this is a Mass Health and Medicaid quality metric, we are asking that everyone begin to look at this opportunity to complete this especially given that the year is already half over when it comes to this quality initiative. On the next slide, you'll see postnatal care. And again, this is again a quality metric which is halfway over. It includes patients with deliveries between October 8th of 2022 and October 7th of 2023. And we're looking at the percentage of patients who have a postpartum visit 7 to 84 days after their delivery. A postpartum visit can include anything, including a pelvic exam, evaluation of weight, blood pressure, breasts, and abdomen, a notation of postpartum care, a wound check of a C-section or perinatal incision, screening for depression, anxiety, tobacco use, substance abuse, or a pre-existing mental disorder. If the patient was a diabetic, glucose screening, and or documentation of infant care, breastfeeding, resumption of intercourse, family planning, sleep and fatigue, resumption of physical activity, or attaining a healthy weight. And again, this is one of the small number of quality metrics for Massachusetts Medicaid. And frankly, we think this will be all Medicaid within a very short period of time. And we're looking for your assistance to make sure if you have a patient who's given birth and is being seen within 7 and 84 days afterwards, please just take a moment to ensure that we're meeting one of these criteria and getting credit for a postpartum visit. Again, most of this will be done by OBGYNs, but any primary care doctor can certainly provide this. Next slide. So in Massachusetts, as you'll see on the following slide, there has been a significant change in terms of their quality metrics. We talked about prenatal care and postpartum care just a few slides ago. We talked about depression screening at the beginning. I do want to talk about follow-up after ED visits and inpatient visits, just so you're aware that these are new pay-for-performance metrics for 2023 as well. On the next slide, you'll see follow-up after hospitalization for mental illness within 7 days. Again, this is a follow-up visit that can be done by telephone, electronic visit, virtual check-ins, or an inpatient visit. And any patient who's been admitted to a behavioral health unit as an inpatient should be seen within 7 days after discharge to make sure that they're getting the appropriate medications. This does not require a psychiatrist to do. A primary care doctor can certainly do this. And again, we're being graded on the number of patients who were hospitalized that get seen within 7 days of discharge. And telephone visits, electronic visits, virtual check-ins like FaceTime are all acceptable in completing this. On the next slide, you'll see follow-up after ED visits for mental illness, same thing. If a patient was seen in the emergency department with a principal diagnosis of a mental illness or intent to self-harm, they need to be seen within 7 days of that visit. And again, it can be done by telehealth. It can be done by a virtual visit. It can be done by an electronic visit or an in-person visit. Anything is acceptable to get credit for this to ensure that the patient is doing well and not likely to re-access the emergency department. And finally, follow-up after emergency department visit for substance abuse. Any patient who was seen for substance abuse disorder or a drug overdose needs to be seen within 7 days of that visit. And again, it can include telehealth, telehealth, virtual visits, telephone visits, or in-person visits. And again, this should include pharmacotherapy with naltrexone or buprenorphine whenever possible to, again, try and avoid the recurrence of drug overdoses for those patients that are at high risk. On the next slide, I want to again reiterate that CME credits are available for providers who are attending the entire aspect of tonight. You will be getting an assessment of tonight's presentation just to make sure that you had a chance to grade how well we performed in terms of educating you. But I hope that this has been educational in terms of identifying the quality gaps that we're really focusing on, depression screening and hypertension, identifying just how important risk coding is in documenting the severity and acuity of illness in adults and in pediatrics, how important performance liaisons are and how they can help you with all of this work, making sure that you understand about patient experience, and then the new metrics for Medicaid and Mass Health, including follow-up after ED visits for substance abuse and behavioral health abnormalities, as well as follow-up after inpatient. Thanks so much for taking time on a Monday night to spend some time with us. If you have any questions, I'll ask Kelsey to read them to me. And if you can't answer them for some reason, please feel free to email your question to shicken.qualityteam@steward.org. We will be sending out the actual presentation about 48 hours from now, but wanted to, again, make sure that if you do have a question, we try and answer it for you. Kelsey?
So we have a few lined up. The first one is, do we need to document in the note for depression screening?
If you have a structured field in your EMR, you should be using your structured field. If you've got Athena or ECW, please use a structured field. But yes, you do need to document that you've reviewed and looked at that score on the PHQ-2. Again, it should be 0 for most of us. But if it's 1, 2, 3, 4, 5, or 6, that you've graded it and that you have a follow-up treatment plan. And yes, that needs to be included in the note.
Okay, if pediatric conditions such as asthma, epilepsy, congenital heart disease, and behavioral health diagnoses have resolved, are asymptomatic, and not requiring ongoing treatment, should they continue to be coded for the remainder of the patient's life?
So if a patient has had asthma, it's a chronic condition and they're likely to have it going forward. And yes, you should code for it. If they had one seizure and it was a febrile seizure, you can certainly avoid coding that. But if they've had more than one seizure and or there's a likelihood that they're going to have seizures again, you should definitely code for it. If they've had a childhood cancer, you should absolutely continue to code for it. And if you have a childhood cardiac condition like a patent ductus, ASD, VSD, you should absolutely continue to code for it. It will be important because that patient will require care over the course of their lifetime, and the severity of that illness needs to be depicted so that the plan knows about the resources that they need to allocate.
Okay, for pre and postnatal care appointments, is that for just Medicaid or commercial insurance as well?
Just for Medicaid right now, but usually what one does, others may follow. But for this year, it's just for Medicaid.
There's a provider in the Neshoba market looking for the name of their performance liaison. So if we could get that info to them.
I will I will work on getting that info to them.
Do specialists need to document depression or just PCP?
I would recommend that every provider evaluate every patient once a year for depression, but definitely it has to be done for every patient. If the PCP is doing it, they certainly can. I will tell you that for many providers, they're emailing a PHQ-2 to their patients 2 weeks before their visit. The patient fills it out and walks into the office and hands it to the provider so that the provider already has it. But again, I recommend that every patient be evaluated at least once a year as a best practice.
Nothing in front of me if we want to wait a minute.
Okay. I just wanted to say thank you. First of all, thank you to my IT team who's been incredibly supportive all day long in terms of making sure that we got these presentations out. Thank you to Joanne Zama, Ginny Rigo, Jess, Kelsey, Dina, and Kim for making sure we've gotten all of the work done that we needed to, and for making sure that the deck was as good as it was. And finally, thank you to each and every one of you for taking time out of your day to attend this. We really appreciate it. Kelsey, any more?
Yes. This one says diabetes with nephropathy versus diabetes with CKD as a diagnosis code.
So there is, if you have diabetes with chronic kidney disease, you can certainly diagnose that. That's certainly a code. And I will get the code for diabetes with nephropathy. I don't have it off the top of my head, and I apologize.
All right, that's all.
All right. Thank you, everyone. Have a good night. For those celebrating Easter and Passover, have a wonderful and happy holiday season. Thank you again, everyone. Have a great night.